Hi guys, it's good to see you back. So today the lecture will be about leukemia, or as we call it, blood cancers. So basically, just to make a brief introduction, lymphoma is different than leukemia. Lymphoma will be the cancer cells in the lymph node or the lymphatic tissue, but here in leukemia the cancer cells are spread or can be found in the blood. That's why it's emia in the end. So leukemia. So basically there are four types of leukemias that are based on, first of all, the growth or the growth of the cancer cells, that is also called proliferation. If it's like sudden, it is called acute, and if it's slow, gradual, then it's called chronic. So acute and chronic, and now based on their morphology, whether they are arising from the myeloblasts or whether they are arising from the lymphoblast. The myeloblast obviously gives rise to WBCs normally, and lymphoblasts give rise to T cells and B cells. So based on those factors, there is a classification of these cancers, and there are four types of cancers that are CLL, CML, ALL, AML. That the full form is chronic lymphocytic leukemia, chronic myeloid leukemia, acute lymphocytic leukemia, and acute myeloid leukemia. Okay, so for the brief introduction, if you have already read this topic, so this will be a quick revision for the same. So the most common leukemia in children is ALL, most common leukemia in adult is CLL. Leukemia that is associated with Down syndrome, the most common leukemia is AML. Don't confuse Down syndrome as the most common leukemia will be found in Down syndrome kids will be AML M7. No, it will be ALL, because still they are children. The Down syndrome kids, if they are younger, they are obviously children. But here we are talking about the association, the strong association of AML with Down syndrome. Okay, so both of these have a very strong association together. And now regarding their clinical features or the catch points that can help you in identifying the kind of leukemia in questions or in the options in the answers. So ALL, so there can be mention of, for ALL and AML both are acute. So the common features of both of them are anemia, HSM is hepatosplenomegaly, and bleeding because there is low platelet count. So along with bleeding there will be purpura, petechiae, okay, and hemoptysis as well. So for ALL, the specific finding will be CNS leukemia. The spread of the cancer is towards the brain as it crosses the blood-brain barrier, and similarly it crosses the membrane and reaches up to the testis. So there is testis lump. And AML, the catch point here is gingiva hypertrophy and chloroma. Chloroma is the patch of like a purpura kind of patches you can see all over the body, but basically we will read about it later. And in CLL, massive splenomegaly, like it will be massive. If here is the spleen, so it will be so massive that it will cross. You can palpate it even beyond the umbilicus of the patient. Now CML, chronic myeloid leukemia. So the finding here will be cervical lymphadenopathy, but the most important catch point here is autoimmune hemolytic anemia and autoimmune thrombocytopenia. Okay, for the diagnosis of all of these, for ALL and AML, we will simply do bone marrow aspiration, since there is a very sudden spread of cancer, so it will be easily found on the blood smear or in the bone marrow. So the investigation of choice here will be BMA, and in CLL there will be FISH and PCR for their cytogenetics and molecular analysis, and in CML it will be flow cytometry. So here I have written all the important points for all of these kinds of cancer. So here you can see there is a table. Well, it's not, I won't say it's like appropriately differentiated among all of these, but the important points or from the etiology to the treatment are mentioned here in this column for each one of these cancers. So let's start with CLL, chronic lymphocytic leukemia. As I already told you, it's the most common leukemia found in adults. So and it leads to AIHA. I have already mentioned it earlier because it's a catch point. So what are the causes for these cancers? So the first of all, chromosomal deletion of which one? 11p, 13p. 13p is the most common, and p is the short arm of the chromosome obviously, and q is the long arm. And if there is deletion of 17q, it has a worse prognosis. And also there is association with trisomy of 12. And also there are two genes that are hyperstimulated or hyperactivated, that are BCL2 gene and ZAP70 gene, and both of these are anti-apoptotic genes. So when they are anti-apoptotic, so cells won't die on themselves, so they will keep on growing, and new cells are all also forming, so there's a cancerous growth. And there is an exception among these cancers. All are associated with radiations, but CLL is not associated with the radiation. Since it's an exception, so it's important to remember. And the clinical features are, as I told you, it's the most common cancer in adults. So the clinical feature will be patient will be presenting with the age of more than 60 years or 72 years. It's a mean age 72 years the patients are fine, and it's more associated with females. So the finding, as I already mentioned, cervical lymphadenopathy, fever, night sweats. So these kind of features are kind of vague features, we can say, because doctors might confuse these features like cervical lymphadenopathy, fever and night sweats with tuberculosis. So that's why. So you have to investigate further, and let's go through more clinical features. So since there is low immunity, there will be more risk of infections. So recurrent pneumonia, herpes zoster virus, herpes labialis. So why there is more infection? Since the neutrophil count, now there are anti-apoptotic genes, so the neutrophils are growing rapidly and they are not dying. So when they are not dying, there are immature neutrophils growing. When they are immature, they are not able to perform their action. That's why there is low immunity, you can say, even though there is ample growth of neutrophils, actually more growth, even beyond the normal limit. Now there are antibodies formation in this kind of cancer against RBC and platelets, so that will cause their manifestations like pallor related to RBC, and platelet will cause petechiae, purpura, epistaxis, and hepatosplenomegaly. As soon as the cancer cells will spread in blood, and they will reach to the liver and the spleen, so manifestation like hepatosplenomegaly will occur. Now for the workup, now what will you do with the patient? So first of all, we have to check the B lymphocyte count that will be seen is more than 5,000. So more than 5,000 for 3 consecutive months. Apart from that, in peripheral blood smear, you can find the smudge cells. So that's finding for peripheral blood, and the indication of choice here will be flow cytometry. Now flow cytometry, it's a procedure of looking out for the CD marker of the cells. So cells will be taken, and there will be marking for the same. So now there are the CLL is so there will be CD marker positive in CLL for 19, 20, 22, 23 and CD5. Now let us go through them. And the CD19 is B cell specific, like you won't find this CD marker in any other cell. So first of all, see, if CD19 positive, we are pretty much sure like it's a B cell found in this biopsy, you can say. Or apart from that, in CD20 is also B cell, you can find that on B cell normally also, and CD22 also. But the CD23 is also found in B cell. Now these markers are found normally in the B cell, but the CD5 is not found in normal B cell. These are normally found in T cells. But when these CD5 are found in B cells, this tells us the B cells is abnormal or it's cancerous. Now there is another disease or the name of the disease is mantle cell lymphoma. In mantle cell lymphoma also these CD markers are positive except CD23. So it's a very close differential between these CLL and mantle cell lymphoma. To differentiate them, we look for CD23. If CD23 is positive, it's a CLL, and if CD23 is absent there, so it's a mantle cell lymphoma. So three markers are important here: 19 for because it's B cell specific, and CD5 because it tells us that the cell is cancerous, and 23 to differentiate it from mantle cell lymphoma. Apart from that, when there is still, it's chronic, right? So it's chronic. First the growth is very slow, gradual, but eventually a time will come, the spread has stormed up, or the spread is now very fast. So in that case, if the progression is fast of the cancerous cells, the lymph node size will start to increase. Okay, so there is a thing called Richter syndrome. So the Richter syndrome is a syndrome when the lymph node size suddenly increases. It's not a gradual increase like day by day or week by week. Suddenly you will feel like there is increase in size of the lymph node, and not only that, it will have symptoms with it like fever and pain in that area or the lymph node. So we call it Richter syndrome, and this Richter syndrome, as you can see, it's already the exacerbation of the CLL, so it can lead to DLBCL, that is diffuse large B cell lymphoma. So that you need to remember. Now for the classification of this cancer, now the classifications are done based on two methods, that are Rai, Savitsky and Binet's classification. I haven't mentioned their criterias for classification, but they tell us the severity of the cancer, like if it's low risk, high risk or very high risk similarly. So low, moderate or high risk. So in treatment, these classifications help us to further treat the patient. So in low risk, we do the conservative treatment because there is no specific treatment for the same. So when there is low risk, not much symptom, it's not bothering the patient much, so we will keep it like that and we will do the symptomatic treatment. But when it's high risk, so there are two regimes that can be followed. One is FCR and the other is PCR. So now the F stands for fludarabine, the C stands for cyclophosphamide or rituximab, and in the PCR, the P stands for pentostatin. So these two can follow depending on which one shows better results. So first, obviously, if FCR is followed first, and if it won't show the expected results, so PCR can be done. And number three, now for the treatment of patients with more than 65 years of age, along with those patients having comorbidities, so therefore obviously high risk patients. So now we have talked about the low risk and high risk patients. Now there is a specific patient, if patients come with the age of more than 65 along with the comorbidity, so obviously he's a high risk patient. So the treatment here will be based on chlorambucil and ibrutinib. Now the ibrutinib is very kind of, you can say, a hardcore medicine. That's why it's also used in chromosome 17 deletion a patient. If there is chromosome, as I already told you, chromosome 17 deletion, the long arm 17q is associated with the worst prognosis of CLL. So in CLL patient, if chromosome 17 deleted is found, then we start the treatment with ibrutinib, which is obviously tyrosine kinase inhibitor. Now the treatment of choice, the ultimate treatment of choice here will be obviously bone marrow transplant, and we call it allogenic bone marrow transplant, because obviously if the medicines aren't working, so we try to replace the manufacturing unit itself, so that there is no cancer proliferation inside the bone marrow. Okay, so that's all for CLL. Now let's go to the CML. So CML is a chronic myeloblastic leukemia, or myeloid leukemia you can call it. So the catch point here is you will find balanced translocation here. Why I call it balanced? Because there is a translocation between chromosome 9 and 22, both having their long arm. So like there is short arms of chromosome 9 and 22 and long arm. So the translocation is from the long to the long arm of chromosome 22. So that's why it's called balance. So if it is like from long to short arm, then it won't be balanced translocation. So, and 922 is a very important chromosome when we talk about lymphoma and leukemias. That's why it has a special name here, which is called Philadelphia chromosome. So let you remember CML, Philadelphia chromosome. Okay. And apart from that, it's also called BCR-ABL1 gene, because the translocation gene over that chromosome, so the one is having BCR and other is having ABL, when they come along, it is called BCR-ABL translocation. Now what this translocation, like it forms a kind of new gene, so but not exactly a gene. So they together they will produce different ribosomes, or proteins that will show their effect. So what are those effects? So there will be increase in tyrosine kinase. So tyrosine kinase, as you know, is responsible for the growth of the cells. So if there will be more tyrosine kinase present, there will be more growth of cells and formation of new cells. So that's a problem. And along with that, not only it increases the growth, it stops the apoptosis of those cells, because it's anti-apoptotic. And also the important point here to remember is it's responsible for production of novel oncoprotein. Now when we say an oncoprotein, this protein is obviously onco, like cancerous. So it is responsible for anti-apoptotic features, and along with that it can also stimulate the growth. So novel oncoprotein, which is called P210 BCL-ABL gene. Now 210, why 210? 210 is the size of that gene, which is 210 Dalton, kilodalton. 210 kilodalton is the size of that gene. And if it's 190, P190, it can form other genes as well. So if it forms like other oncoproteins as well, if it forms P190, which is commonly seen in ALL, which we will read after this. So when 190 is formed, but if the 190 is found in CLL, then it is associated with bad prognosis. And if P230 is found, similarly 190, 230 are the kilodaltons size of this oncoprotein. So if 230, it's indolent, like it won't cause much effect to the patient. So now the clinical features here, like remember it, CML, all these three letters are different, CML, so there will be triphasic deterioration of this patient. So what triphasic is, so the first phase will be chronic phase, then accelerated phase, then blast crisis. So the chronic phase is, in chronic phase, if the patient comes to you in a chronic phase, so you will find there is less than 10% blast cells in peripheral blood or bone marrow, so less than 10%. So you can see, yes, there is, but it's slowly progressing, it's not that fast. Then there will be a phase for the same patient, maybe later, if not treated, later it can go into accelerated phase. In accelerated phase, in peripheral blood, you can find more than 15% blast cells, or you can find more than 30% blast cells along with promyelocytes. All right, so these the two criteria are mentioned in the latest latest updated version of Harrison. So there it is mentioned in accelerated phase more than 15% and or more than 30% along with promyelocytes. And then or you can, the earlier criteria was more than 20% basophils. So that is all still there. But in peripheral blood, more than 20% basophils, or in and platelets less than 1 lakh per mm cube. And now after the accelerated phase, there is blast crisis. So as the name suggests, it's a crisis. So it's acute and it's a very terrible situation for the patient, and it's also hard to treat. So in blast crisis, there is more than 30% blast cells in peripheral blood and in bone marrow. Along with that, there is extramedullary spread also. Like extramedullary means apart from the bone marrow. So where can be these cells found? These cells can be found in lymph nodes, spleen and liver. So basically these three organs are common, like lymphadenopathy, splenomegaly, hepatomegaly. You will hear in like any of these cancers, because it basically suggests the spread of the cancer. Now the clinical features will be non-specific fever, just like CML, so CLL, sorry, non-specific fever, weight loss, fatigue, sweating. And since it is CML, so M myelocyte or myeloblast, and it's responsible for the proliferation of WBC, so there will be the growth here will be related to the basophils. So you will find basophilia. Now the basophilia is there, so obviously there will be histamine, and also basically the patient will feel pruritus over his body. So pruritus will be there. And massive splenomegaly, as I mentioned already, massive splenomegaly, early satiety, because of the spleen has been enlarged in size, so it will kind of compresses the GI system, so there will be early satiety and constipation in the patient. And obviously lymphadenopathy and hepatomegaly. Along with that, there will be thrombotic events. Why there will be thrombotic events? Not because the platelet has been increased in size, but in blast crisis there is a term called leukostasis. So what is leukostasis? When the leukocytes increase in number, like more than 1 lakh, when they are supposed to be in a range of 4 to 11k, they exceeds the limit, like it crosses 1 lakh number of cells. So there will be, just imagine, the blood will become so much thicker. It will be so much thicker, it will be so much viscous, that there is circulation compromisation will be there, and because of that sluggish movement there will be stasis. That's why it's called leukostasis. And when there will be stasis, and anything which remains at a place for a longer time, it will start to have thrombosis in within it. So there will be thrombosis. So that is why thrombotic event is mentioned here, because of the leukostasis component of this disease. And this leukostasis component, because there is sluggish circulation, so the most uh, organs that are mostly affected by this leukostasis are brain and lungs. And if the brain is involved, if the brain is not getting enough blood supply or the essential elements from the blood, then it will start to show CNS features, like simply getting unconscious, confusion, and things like that. And if the lungs is involved, then there will be ARDS. It can lead to ARDS, like there will be deposition in the alveolus, and then there will be perfusion and ventilation mismatch. It will lead to ARDS. Okay, so other complication will be there. So these two organs are very much affected by leukostasis in all of the cases. Like in general, this is what leukostasis does. And along with that, there will be priapism, blindness because of this circulation compromise, blindness. And there will be thrombosis, as I told you, so myocardial infarction, deep vein thrombosis. And now in the what happens to the cells is, this is also very general thing. First of all, there is hyperproliferation of the cells, like in the bone marrow there is growth of RBCs growing here, and platelet is growing there, WBC is growing there. Okay, the B lymphocytes are growing here. So when there is a start of the cancer, okay, so the B lymphocyte, or you can call it the myeloblast, like they are proliferated, they increase, there is an increase in production, so they kind of simulate other cells. So in the beginning, all of these kinds of cells will start to increase in number, but the main affected cell here is myeloblast. So a time will come when there is so much production of myeloblast only, that it will kind of it will kind of occupy the whole space of bone marrow. And similarly there will be decrease in number of other cells like RBC and platelets. If you are getting my point, like from a bone marrow there is increase of myeloblast so much that it kind of the RBC and platelets gets compromised. They don't get enough space in the bone marrow. So there will be thrombocytopenia. So the symptoms of thrombocytopenia will be there. So like at the earlier stages of the cancer, in chronic stages, there will be increase of platelets, but as the disease progresses or gets worse, in particularly in this disease where there is blast crisis phase, the platelets will decrease. So symptoms will be petechiae, purpura, hematomesis and hematochezia, things like that, like bleeding. Okay, so the workup for CML patients will be, first of all, the HB would be found normal, either normal or decreased, and the TLC will be elevated, leukostasis. Okay, so the leukostasis is the point here to mention is leukostasis is the more incidence is found in AML as compared to CML. In acute phase, leukostasis is found because, as I already told you, in CML also, in the blast crisis phase there will be leukostasis, but where there is acute myeloid leukemia, there is already a sudden onset, so leukostasis will reach earlier there. So there, similarly, there is more incidence of leukostasis there in AML. So moving on, in there will be basophilia. Okay, but here in CML there will be no maturation effect, arrest, like the stages. Maturation arrest is, there is in other cancers what happens is the cell grows, so cell have different stages. So what happens is the cell will reach up to like stage 2 and won't grow further, so it's still immature until it die. Okay, or it is being killed by chemotherapy, so it remains in immature phase. But here is no such thing as arrest, maturity arrest. What happens is the growth of the cell is so much more that the cell which has been formed earlier doesn't get enough time to get mature and get spread into the blood as a mature cell. Rather, the immature cell's growth is so much more that it kind of burdens up there. Okay, so no mature. So now NAP score, that is neutrophil alkaline phosphatase score. As I already told you, the neutrophils will grow, and to mention, it won't be like the number will be more, but the cells won't be mature enough to perform their action. So now when the neutrophil alkaline phosphatase score is a score which tells you if the neutrophil is capable to do the function. Okay, so if the cell is not capable to do the function, the score will be low. Okay, and the other thing which can be found in blood is serum vitamin B12 is highly elevated here. So the indication of choice here will be cytogenetics, which will be done via FISH test, and molecular evaluation, which will be done by PCR. And apart from this, we can do bone marrow aspiration. Bone marrow aspiration, we will find myeloid erythroid ratio to be 15:1, something like that, and hypercellularity, WBC of different stages will be seen. As I already told you, growth is so much that all of them like are coming, they are not even waiting in the bone marrow to get mature, they are just flowing into, there is an influx, like vigorous influx in the circulation. Okay, then there is something you will read in pathology, that is pseudo-Gaucher cells are present there, and also the reticulin level of reticulin in BMA is also elevated. So the treatment of choice here obviously will be, well, just remember it. Wherever you will read Philadelphia chromosome, that means it will increase tyrosine kinase, which will stimulate the growth of the cells, leading to cancerous cells. So the treatment here will be against that tyrosine kinase protein, which is stimulating the growth. So the treatment of choice here will be tyrosine kinase inhibitors. So tyrosine kinase inhibitors, the examples here are imatinib. So first of all, imatinib will be given. Then second line, if imatinib is not successful enough, then we will give dasatinib or bosutinib. Imatinib, if there is imatinib resistance, the cancer cells are not even responding, just a little bit they are resistant to imatinib, then we will just give bosutinib. So it's like a boss of imatinib. So bosutinib. Then third line of drug is ponatinib for T315L mutations. So there is other mutation associated with this disease, so there we will give ponatinib. Then omacetaxin, when failure of two tyrosine kinase, more than two tyrosine kinase you have already tried, but they have all failed or both of them failed, then we will give omacetaxin. Okay, so but in blast crisis, when there is like a very bad situation, what we will do, we will try to give tyrosine kinase inhibitor. Like the patient came to you with a blast crisis phase and haven't taken any treatment before. So you will first of all you will start with tyrosine kinase inhibitor to see if it affects, but the ultimate treatment of choice here will be allogenic stem cell transplantation. We will just transplant that bone marrow thing. All right, so now you have given these treatment. Now there are three classifications you can put your patients into depending on the response to the treatment. So if the response is good with the medicines, it is more, is it moderate, it is bad, and how will you check it? So let's go through that. So the three classification measure, first one will be cytogenic response. So in cytogenic response we will see the antibodies, sorry, in cytogenic response we will look for the Philadelphia chromosome cells, like cells having the Philadelphia chromosome in them, and the metaphases. And if they are absent, like totally absent, then we will say okay, the response is cytogenic, it's kind of good response. Then there will be response, next response will be molecular response. And after molecular response, the third kind of response is major molecular response. So in molecular response there will be less than 0.1% of BCR ABL genes, the same related to Philadelphia chromosome, so less than 0.1% present in blood. And in this 0.1% you can also write it down as more than 3 log reduction from the baseline. So like 3 log reduction has been there, it has been reduced like that. So it's basically mathematical calculation. And in major molecular response, like there is major, that was molecular response, this is major molecular response, so there will be less than 0.0032%, like that was 0.1%, this is 0.0032% decrease. Or you can find the cells in the bone marrow aspirate, or in the log form similarly you can write it as more than 4.5 log reduction from the baseline. Okay, now there is a kind of CML that is called atypical CML, where the patient is having chromosome 20q involvement or defect, but there is absence of ABL BCR genes, there is no Philadelphia chromosome present there. So that you can call it then you can call it atypical CML. Atypical because there is absence of Philadelphia chromosomes, and the treatment of choice here will be allogenic stem cell transplantation. Well, I told you this atypical because to mention the allogenic stem cell transplantation, where else it is used. So allogenic is used in atypical also. Okay, so it's also allogenic stem cell transplantation is also used in juvenile myelofibrosis syndrome. So there also you can do. Now I have mentioned here potacath. So potacath is used to administer the chemo. Okay, in chemo treatment, like usually what people do is put the IV cannula and start the flow of inflow or injecting the chemo, but usually there is a risk of thrombophlebitis there. So there is risk of infection if there is any mismanagement with the needle, then there can be ulcers and they have a lot of side effects. So what we prefer is potacath. Potacath is kind of like a thing will be sticked outside to your body here, and there will be a pipe going inside. So there is a permanent, it's a kind of it is administered first for a long term use. So potacath is directly, the injection is in the subclavian vein. So later you put your chemo here at that attachment, and then it injects in the subclavian vein itself. All right, so we read about CML. Now let's start reading about ALL, acute lymphoblastic leukemia or acute lymphocytic leukemia. So basically, when lymphocytes, as I already told you, can produce B lymphocytes and T lymphocytes. Now the cancer is affecting the lymphoblastic cell. So it can lead to B, it can lead to C, but T, sorry. So B and T, but the most common here will be B. So the B cell has 76%. 76% patients are found having B cell B cell ALL, and the rest 24% cells, 24% patients are found to have T cell ALL. So how can you differentiate B and T? So basically there is very simple thing, as I already mentioned, Philadelphia chromosome. So the Philadelphia chromosome, if it's there, the translocation of 922, then it is then it tells us it's a B cell ALL. And when there is cytoplasmic CD3 or surface CD3 found 3, so 3 means T cell lymphoma. Oh, sorry, T cell ALL. All right. So what are other clinical features of patients having T cell ALL? Make note, I am talking about T cell ALL, the features. So the first feature will be mediastinal involvement. So the mediastinal involvement will be there. So what are there in mediastinum? There will be hilar lymphadenopathy there, and TALL crosses blood-brain barrier, and it also causes meningismus and testicular lump. As I told you earlier, in ALL, remember CNS spread and testicular spread as it crosses blood-brain barrier. So basically, it is highly associated with T cell ALL. All right, so you have to remember it like that. Now the causes for ALL. So the causes of ALL, there is a mnemonic which is A B C D I F K N. So just remember it like ALL. So all alphabets. So A B C D. Then I F word F K N. I fucking know, or something like that. Okay. Then in the last P, that you don't even need to remember, I already told you. So let's start with A. So the A will be ataxia telangiectasia. So these are basically the causes. If the parents ask why this happened to my child only, so they are the factors that you can relate to and explain them. So ataxia telangiectasia, then there is Bloom syndrome, or there can be an exposure to benzene, that is a petrochemical. Then chemo, if the patient had a kind of cancer earlier, so the chemotherapy may predispose to a or simply ALL. It can predispose to ALL. So it's a kind of side effect of the chemotherapies. Okay, and then Down syndrome has an association with this. And infection, what kind of infection? There is very specific infection, that is Hlv-1 infection. We will talk about this later. It's a kind of viral infection, so it can also cause this ALL. And then there is Fanconi's anemia. Now about anemia, I want to tell you, if there is any kind of anemia that is an aplastic anemia, that is already a risk factor for a blood cancer. So Fanconi's anemia has its association not only with ALL but also with AML. So I have mentioned it here already. Now there is another thing from K, Klinefelter and neurofibromatosis type 1, then Philadelphia chromosome, as I already told you. And from the I forgot to mention earlier, you can remember ionizing radiations. So tell me which cancer is not associated with the or doesn't have a risk factor as ionizing radiations. It's CLL. Apart from CLL, all other cancers are prone to have a risk factor of ionizing radiation. So we should avoid, uh, especially children should avoid going through these ionizing radiations. Other translocations that are already also associated. So we talked about one translocation, the Philadelphia one, which is a balanced chromosomal translocation among the long arm of chromosome 9 and 22, which is also called BCR ABL translocation. Alright, so apart from that, there are other translocations as well, that are 411, 814 and 119. 814, in front of 814 I have written Burkitt's. So in Burkitt's lymphoma also there is a translocation of 8 and 14. So that's why I have written it there. And the Htlv-1 infection, I told you. So basically this infection is human T cell lymphotropic virus 1. Okay, it's a kind of retrovirus, so this infection can also cause, the name is itself very much I think if you are familiar about this, it's well and good, but most of us are not familiar about this virus. So you can just Htlv-1 V is obviously virus, so just remember it with the L lymphocyte LV. Okay. Then and this virus, what can this virus cause? This virus can cause two things. One is obviously adult T cell leukemia, and the other is tropical spastic paraparesis. So in adult T cell leukemia, when you will see the blood smear, in the smear there will be a flower pattern kind of a cell. You will obviously identify it's an abnormal cell, but the flower is very much prominent, that you can identify the flower. It's like a basophilic cell. Similarly, it will be a lymphoblastic cell, but in a flower shape. And in CNS leukemia, when there is a patient will come to you, he has or he or she has ALL, and there is a risk of CNS spread. So what you will do, you will do a CSF examination. In CSF, you will find the number of leukocytes elevated, which is usually not even, I guess, low or absent. But here you will find a elevated number of leukocytes, so which is also suggestive of meningeal or meningismus or CNS spread of the cancer. Now the clinical features. So the clinical features will be 2 to 8 years of age or more than 50 years of age. Stormy onset. Stormy, acute, obviously because it's acute, the onset will be stormy, very fast, and therefore the HB will be decreased, platelet decrease. I already told you why these cells decrease with the acute or the stormy thing. Now the sternal tenderness. What is sternal tenderness? You don't get confused. Sternal tenderness, like a baby will come to you and you will keep the hand over the baby and baby will start cry. First you will think like baby doesn't like strangers to touch it, and they'll start cry. But the parent will tell you, no doctor, even I will touch over his or her chest, he will start crying loudly. So what is it? It's sternal tenderness. And why it's happening? Because there is acute onset or stormy onset. There will be a very hyper proliferations of cells in the bone marrow. So basically here is the growth of the cell. What will that cause? That will cause a kind of I won't say inflammation, but since there is a lot of cells growing inside the bone marrow, so the bone will kind of stretch and the osteum will stretch. The osteum will cause pain. Okay, so even a small pressure over it will cause pain. That's the reason for sternal tenderness. Then in CNS leukemia, what will be there? There will be increased intracranial pressure, and obviously it can cross and reach to testicular lump can also be found. Recurrent infections, hepatosplenomegaly, lymphadenopathy, I already told you why it happens. Now workup. For the workup, first of all you will do the CBC. You will find low HB, TLC will be elevated, leukostasis will be there, and AML is more associated than ALL for leukostasis. Now the platelets will be decreased, so similar features of low platelets. Then in bone marrow aspiration is the indication of investigation of choice. Sorry. So you can do the bone marrow aspirate in the posterior superior iliac spine, and with the help of Hlmr needle or Jamshedi's needle. So the Hlmr is a reusable needle. So just to mention it here, Hlmr and Jamshedi. And the findings from that aspirate will be the blasts will be more than 20%. So more than 20% is like you will, it's a WHO classification thing, so you will just call it 20%. Just remember 20%. Even in pathology, most of you must have read 20%, more than 20%, thing like that. So 20% is very common. So the 20%, more than 20% diagnostic feature. Then morphology of the lymphoblast. Now the lymphoblast itself have a morphology, and there are three varieties: L1, L2 and L3. The L1 is the most common one, and in L3 are the kind of blasts that are also seen in Burkitt's lymphoma. When they are also found in Burkitt's lymphoma, so they are also associated with mature B cell ALL, so CD10 surface IG, and then translocation of 814, 822 and 28. So most of these cells, cancerous cells, are usually L1 type, but when they are found to be having an L3 type, then they are suggestive of these diseases like mature B cell Burkitt's, CD10, the cells having CD10 marker, then these kind of translocations of 814, 822, 28. 814 I already told you is Burkitt's lymphoma. Then CD19 marker will be found there, which is used for targeted therapy. CD19 is present. Okay, now what to do? It is done just to make your further treatment, now what to do. If tyrosine kinase inhibitor is not working, what to do? Okay, we can do a targeted therapy against what? Now for that, this test is done and CD19 is looked. If the CD19 is present over there, then we are like kind of, we get an idea, okay, we can give this patient a targeted therapy. Then there is FISH for cytogenetics, obviously, and the high risk in the cytogenetics, if you will find the translocation of 922 or 814, 411, 119. I have already talked about most of them earlier also. So these are high risk. And if the TDT is positive, which is TDT is positive basically in all uh, lymphocytic cancers or leukemia. So TDT is positive in most of them. So what is TDT? Basically it is for DNA polymerase, which triggers abnormal mitosis. So there is abnormal division. Now in lumbar puncture, what will you do is, I already told you, for we do CSF test to see if there is CNS spread or not. So in the lumbar puncture, what there is a chance, like there is a risk the cancer can spread to other tissues as well. Like you will puncture the theca or in the spinal cord, the meninges, it can spread, like it's a fluid, so it can spread to other areas as well. So to avoid that or to prevent that, just after you are done with that CSF examination or lumbar puncture, what you do is you administer an intrathecal methotrexate to avoid this kind of spread. So that even if the cancer spreads just oozed out a little bit, they are just died right away. So this is followed. After that, you will see the baseline, just a serum analysis like uric acid, phosphate, and potassium and calcium. So these are basically done to detect if there is tumor lysis syndrome already manifested or not. If the tumor lysis syndrome is already manifested, so there is killing of tumor cells or other cells. So killing of cells releases these uric acid. Since there is DNA, so uric acid will be elevated in blood, phosphate will be elevated in blood, potassium is potassium stays inside the cell. Now the cell is lies, so the potassium will be also elevated in the blood, but the calcium will be reduced. Why the calcium will be reduced? Now what happens is, when the phosphate is already elevated in the blood because of the tumor lysis syndrome, the calcium kind of chelates with it, and therefore the ionized calcium form is decreased. It's not like the calcium is decreased in blood, the ionizing form of calcium is decreased, because the ionized form is already chelated with the phosphate. If the phosphate would not have been in the blood, then there will be no effect to calcium. The calcium ionized form will be there as it is. Okay, I guess you got my point. Now HLA matching. So the HLA matching is done. This is also a kind of just like CD19 to for the prognosis or for the treatment modality. This is also kind of future planning for HLA matching. HLA matching is done for the patient along with their parents or sibling to see if needed. So can we do the stem cell transplantation in the patient or not? So we need to find a donor already to prevent like hassle later. So we already kind of like associate, okay, the matching has been done between the son and his brother. Okay, so we will use his stem cell if needed. So HLA is done, that's why it's priorly done. Now in standard ALL is same. Now there is different. Now the ALL is also divided in their risk factors like low risk, standard, high risk, and very high risk. So low risk has like vague features like weight loss, fatigue, and all. I haven't written it here because it will get, this video will go like beyond 1 hour. So low risk. So low risk and standard. So I have written this classification along with their treatment. So low risk and standard. So they will these patients will have chemotherapy. So standard is basically standard ALL is same as low risk ALL, but there will be normal cytogenetics like the translocation. I already told you that here there will be no translocation in standard. The translocation thing will be normal here. No abnormality there. Apart from translocation, all other features will be same with low risk ALL. Then in high risk patient we will do stem cell transplantation, and in very high risk that patients are already on verge of dying and they are having a bad prognosis, we will kind of do the tyrosine kinase inhibitor. We will give and targeted therapy because the cancer is already spread in blood and all other organs. So even if we just transplant the stem cell, still the cells are present in the circulation already, you know. That's why we avoid doing stem cell transplantation here, and we will simply administer anti-cancer drugs that are tyrosine kinase inhibitor, and we will do the targeted therapy. And I hope you already know the targeted therapy is done against which CD marker. Yes, you are right, it's CD19. Now adult B cell ALL. In adult B cell ALL, 25% cases adult B cell ALL, as I already told you, the different classes of ALL, so you must have already got the idea. So 25% cases have Philadelphia chromosome in them. Now, as I mentioned you in CML, when Philadelphia chromosome is present, tyrosine kinase elevated, anti-cancer drug will be tyrosine kinase inhibitor to decrease the growth or mitosis. So here the drug will be dasatinib and linotinib. So tyrosine kinase inhibitor have a suffix that is tinib, okay, that you can also read in pharma and all, just a thing to remember in general. So dasatinib, nilotinib. Now immunological therapy, we will do, this is a new approach. Since it's a new approach of treatment, you need to remember it. So in immunological targeting, there is blinatumomab. There is monoclonal antibody formed for this kind of cancer, blinatumomab. And apart from this, there is also a different approach, that is CART19, which is basically antigen receptor of T cell. It works on that receptor, CART19. You just remember CART19, or you can also remember is CAR T19, just to differentiate it. T cell, okay, T19. Okay. Now what we usually do is we perform chemotherapy in these patients, but there is a different phase of treatment. Like it's not a short period treatment, it's a long period of treatment. So we will start with the induction 1, then induction 2, then consolidation, which will take about 14 to 28 weeks, then maintenance for 2 to 2.5 years, and then if maintenance is the last form of treatment, but then later we have to see if there is relapse of the disease of the cancer. For that, the diagnostic procedure is if there is more than 5% of ALL cell present in blood or bone marrow. If more than 5% is present, then only we can say yes, the cancer has unfortunately relapsed and we have to start the treatment again. So you can read these drugs. So induction 1, induction 2. So induction, we are starting it, induction 1, then induction 2, then we have to do the consolidation, okay, then maintenance. All right, okay, let's jump to the last cancer, AML, acute myeloplastic leukemia. So there is very bad prognosis in AML. Like you can read here, there is 5-year survival rate. The 5-year survival rate after the diagnosis of the patient is only like 25%. So it is associated, highly associated with the Down syndrome, but not just AML. AML also have further types like M1, M2, M3, 4, 5, 6, 7, 8, like this. So the M7 type of AML is highly associated with Down syndrome, like even more than ALL. Okay, usually ALL is most commonly associated with Down syndrome. As I already told you, since it's a child, so ALL will be associated, but if the AML is present of M7 type, then AML is more susceptible to occur. Then leukostasis. Leukostasis is also seen here. So leukostasis, you must have read leukostasis in basically like multiple times now. So just to clarify the confusion, so most commonly leukostasis is seen in AML, then CML. So the myeloid, you can just remember it, myeloplastic. Okay, so there will be WBCs elevated, so obviously M will come first or earlier than L, lymphoblastic. So AML, it's acute, then CML, and then at the third there will be ALL. Okay, then there will be chances of DIC. Why DIC is going to happen? When there is leukostasis and other features as well, then these cancer cells of AML has OU rods, AUER, I don't know how you pronounce it. OU rods are there in the cells, and they are present even normally in all kinds of myeloblastic cells. Okay, so iroids is present. Now there are more iroids present because there is a proliferation of this myeloblast. So what happens is when iroids comes or there is a flux of iroids from the cells because of the destruction or lysis of the cancer cell, the iroids will cause DIC in the patient. Okay, so this is also a very deadly situation. So earlier we used to give a medicine for AML, sorry, which is I will just show you, cytarabine. Cytarabine, this blue written thing here. Cytarabine was given earlier for AML, but it kind of, it goes and just simply kills the myeloblastic cancer cell. Okay, its job was very specific. It will go and kill. But what happened after killing the cell, the iroids will come into the circulation and it will cause DIC. That was the problem that would lead to death, not because of the cancer but because of DIC. Okay, that's why we changed the medication for this specific M3 type of AML. It used to occur in M3 type of AML most commonly, so we changed the medication and we started to give I will just tell you later in the medicines. Let's go through the clinical features. Okay, so DIC. After DIC, the causes for this is idiopathic most commonly. Idiopathic is there. Other than that, bone marrow failure, as I already told you, Fanconi's anemia, if there is any condition that is causing aplastic anemia. Okay, then this condition will occur. Other pediatric malabsorption syndrome are there. Schwarzman, Diamond syndrome, and Diamond Black syndrome is there. Diamond. Then Down syndrome. Just remember, you must have remembered it already. Like uh, Down syndrome with M7 variety. Then defective, and this M7 variety of AML is also called megakaryocytic leukemia, so don't get confused. Okay, so megakaryocytic is M7 AML. Then defective DNA repair, Bloom, ataxia telangiectasia. We also read these causes in ALL. So Bloom, ataxia telangiectasia, then alkylating agents, which are also anti-cancer drugs, and also topoisomerase 2 inhibitors. These are also anti-cancer drugs. So see, these drugs can also cause AML. Just there are few associations with them respectively. With the alkylating agent, if the patient is having monosomy of 7 or of 5, then there is a high risk of the child getting AML. So there is 4 to 6 years. It takes about 4 to 6 years after administration of alkylating agents to cause AML. Similarly, topoisomerase 2, if there is chromosomal defect of chromosome 11, then it will take about 1 to 3 years to cause AML. Then obviously radiations, benzene, chloramphenicol, radiations and benzene you must have read already in previous sections. And in chloramphenicol causes aplastic anemia, which also predisposes. Then chromosomal swaps are there. Chromosomal swaps are like a simpler term for that translocation, as I told you earlier. So translocation of 821, which is also called run X1 T1. Okay, that's it's a name for this translocation. Run x1, run x1 t1, then inverse 16 or t16-16 translocation, or t15-17 translocation. T15-17 is also called PML RARA. PML RARA is highly associated with M3 AML, which I told you. M3 is associated with DSE, and how it is associated. PML RARA, when there is PML RARA, it is highly associated with M3 kind of AML, and this M3 kind of AML is called acute promyelocytic leukemia, APL. Acute promyelocytic leukemia, when treated with cytarabine, it releases IO rods and it can cause DIC. And apart from these causes, there is mutation also, the mutation of FLT3 gene. FLT3 gene, 30% of cases are found to have this mutation FLT3. And when the markers for a better prognosis, like the disease itself is having bad prognosis, very bad prognosis, but still if there are these genes present or these factors present, then we can say it's kind of within this disease it's a better, still better, not that bad. These are FLT3 gene, CEBPA, NPM1, translocation 822, inverse 16, and 1616 translocation. Now the clinical features is obviously it's acute, there will be stormy onset. So the patients here are quite old, so geriatric population is involved here or commonly seen here, so more than 64 years of age. Then fatigue, pallor, dyspnea, those vague symptoms. And TLC is dropped. When the TLC is dropped, it will cause infection, therefore fever. And when time will come when there is like the spread is very gradual, then it will cause leukostasis. Leukostasis will be there, platelet will decrease, DIC, gingival hypertrophy. As I told you in the beginning, the catch point, gingival hypertrophy will be seen with bleeding. And when the patient is having gingival hypertrophy with bleeding in AML, it is suggestive of the M5 type of AML. So there is a table in pathology for each one of types of AML, like M1, as I told you, M1 to M9 or 10. So you can just read it from there. I have mentioned the important M's here, the subtypes here. Then hepatosplenomegaly, CNS leukemia, it is more commonly seen in ALL. CNS leukemia is a catch point for ALL, but can also be seen in AML. Okay, then chloroma will be present, okay, which is called as myeloid sarcoma. So the myeloid sarcoma, on the back of the patient, there is an image. On the back of the patient there will be patch, like purpuric patch, something like that, but a lot of them, so those are called chloroma. Then spinal granulocytic sarcoma, now the spine is involved and it will put pressure on the spinal cord and it can cause quadriplegia, paraplegia. Now for the workup of AML, indication of choice is BMA. For both AML and ALL, BMA is the indication of choice. So diagnosis is more than 20% myeloplastic cell, as I told you earlier, or anyone present. Either there is more than 20% or there is presence of translocation 15, 17, 8, 21, inverse 16, 16, 16 with 10 to 15% myeloblasts. And then also if there is presence of IO rods in the blood, which already means like there is hyperproliferation of myeloblastic cells and they are lysing. Then CD13-14, CD41-61, which is associated with M7 type 41-61. So just you have to mug up these things, like ratta karo sabka, और कुछ नहीं कर सकते. Now apart from that, the other mode of investigation is cytogenetic molecular. You will read multiple times the cytogenetic and molecular analysis. Just associate the cytogenetics is done with fish and molecular is done with PCR. Okay, this is general rule, remember it. Okay, so there we can find FLT3, CBPA, we already did it. Then we will do the HLA matching similarly for transplant, and chest x-ray will be done here for to see if there is hilar lymphadenopathy. Echo will be done to see if the heart is performing normally or not, because we have to give some certain chemo In chemotherapies we have to give some anti-cancer drugs that can cause that can lead to heart manifestations. To avoid them, we do the echocardiography prior to it. Then there is KFT. We will do the kidney function test to see if there is finding of abnormal elements, as we did earlier, to see if there is tumor lysis syndrome present or not. Then CBC, same, HB will be dropped. TLC, first it will be dropped, then later there will be leukostasis, so it will be elevated, highly elevated, then platelet will be dropped. So the kind of anemia here will be, in all of the cancers, the kind of anemia will be normocytic normochromic anemia. Okay, then in the types, M2 is the most common type, M3 is associated with IU rods. Okay, so now the treatment, since cytarabine is not used for M3 type of AML, we will give ATRA, that is all transretinoic acid. So ATRA is the treatment of choice in M3, and the translocation 15-17 also, you have to remember this. Now the treatment. So the primary, first of all, we will give the primary chemotherapy, that is cytarabine along with anthracyclines. Anthracyclines, it can be idarubicin or daunorubicin, but cytarabine will not be given in M3 type, obviously, to avoid DIC. So in M3 type we will give ATRA plus arsenic trioxide. Now the side effect of ATRA, that is all transretinoic acid, is there is a thing called differentiation syndrome. So now what will happen, the immature cells, obviously there is differentiation arrest, that's why they are immature, they are still immature and they are not differentiating into mature cells. But ATRA mature these cells. Now there is already a lot of cells present, immature cells, in like highly amount are present in the circulation or in the body. So now when ATRA will come to action, there will be a lot of mature cells. Like there will be excess of, first there was excess of immature cells, now there is excess of mature cells. Now what is the problem here? The mature cells have a nature or have a tendency of stickiness, like they are more sticky than immature cells. Now when they are more sticky, what will happen is they will just stick in the circulation, where most commonly they will affect the lungs. So they will stick to the alveoli of lung or alveolar wall, similarly causing perfusion and ventilation mismatch, which will lead to ARDS, and later we have to give steroids for them. And there is like 10% mortality rate for patients dying with, there is tendency for patient to die with the 10% mortality rate of ARDS in these patients, AML. So for the treatment, steroids are given in ATRA. Apart from that, okay, so basically this is done. It took almost an hour or so, but I hope you don't need to revise it again. You can just take the screenshots from this video, and that's all. Now if you will read this small paragraph written in front of you, you can recall many things, and you can even recall the whole of the topic. Okay, thank you very much guys for listening me out so patiently. If you are still here, thanks a lot and all the best.